When I got involved, I was doing underwater acoustics in a restricted area called acoustic cavitation. And it turns out that acoustic cavitation has become a pretty important part of therapeutic ultrasound. I was struggling with getting support for my research, and I got offered a job as a scientific director of a small company in California which was trying to use HIFU. And I didn't even know what it was. And I found that actually the cavitation work that I was doing and the physical acoustics work that I was doing was really relevant to the whole concept of HIFU, because if you have high intensity ultrasound in a liquid system like our bodies, you get cavitation, and cavitation is a way to damage tissue. And I noticed that in killing tissue with temperature, you also cauterize the blood. And at the same time, we were in the Iraq War and in Afghanistan, and a lot of the soldiers were dying of exsanguination. Half of the soldiers who die on battlefield die of exsanguination, which means bleeding to death. So the idea that you could use ultrasound to detect bleeding and ultrasound to cauterize tissue, then I conceived of the idea, we together conceived of the idea of acoustic hemostasis. And I wrote a proposal to the Defense Advanced Research Projects Agency to do acoustic hemostasis. And they gave me $10 million to do that, and so, which is a big grant. And so I used that to establish the Center for Industrial and Medical Ultrasound, and we focused on acoustic hemostasis. But acoustic hemostasis is essentially just a variation of using image-guided high-intensity ultrasound to kill tissue. It was a brilliant idea that come up. It was the right time, because you could use an ultrasound machine to image any place in the body that the field would see, and that was just, except for the brain, you could essentially image any region in the body. And they had developed also the concept of Doppler, which means that any kind of blood flow you could also image with ultrasound. And so if you could image any organ in the body, including tumors, and you could use the same technology, the same transducer, in a sense, to apply higher intensities, then you could do what I called image-guided, transcutaneous, bloodless surgery. And it caught on. When you're a kid, you often get your first magnifying glass. And this is a wonderful toy, and you use it to look at things, and then you get the idea, or somebody tells you, that you can focus the rays of the sun that doesn't do any damage to the sun. It's wonderful to have sunlight on you, but if you focus the rays of the sun down to a spot, you can start a fire on a leaf or on a piece of paper. And so then I thought, well, ultrasound is a wave, and sunlight is a wave, light is a wave, and ultrasound is a wave. But the light doesn't penetrate the body, but ultrasound does. And I thought, now you could cause a fire, you could cause cauterization in the middle of your body, anywhere that ultrasound could penetrate. All you have to do is focus it. So that just seemed like a remarkable advance. Other people sort of picked up the idea, because once you had the idea that you could treat almost any place in the body that you could image with ultrasound, seemed to me to be the revolution in medicine that was waiting. I have a daughter who is a surgeon, and I used to say to her, the ancient Egyptians used scalpels. And then we advanced, and maybe 20 years ago, people thought about, well, why not use minimally invasive surgery, in which they use laparoscopic techniques. And now we don't have to break the skin at all. We can do everything transcutaneously. And so now once you had MR guided HIFU with MR developed thermometry, you could cure almost any disease you wanted to cure. And I think that is still the future of image-guided therapy. A big problem was uterine fibroids, because 30% or some high percentage of women sometime in their life get a uterine fibroid, and my wife suffered from them for many years. And the typical standard of care was to perform a hysterectomy. In almost all cases, they just did a hysterectomy. And that also had a lot of morbidity. You no longer were fertile, could have children. And this idea of seeing a uterine fibroid with ultrasound or with MR, that was easy to see. And you had a very clear organ or a clear set of tissues to treat. And so I thought that was a good idea, and then the FDA asked me to be on a panel to approve it, to consider it, approve it. And I thought that the presentation that was made by the women gynecologists who are saying, my gosh, I've got all these women who they want to remain fertile, and I perform hysterectomies on them, now I can treat them with HIFU, and it'll be a wonderful thing. And so I strongly encouraged the FDA to approve it, and they were. Now, what held things up, though, was insurance companies still considered it, at least in the United States, an experimental treatment, and they wouldn't provide reimbursement. And so as a consequence, that slowed down greatly, I thought, the acceptance and widespread acceptance within the clinical community. And that's a problem, particularly in the United States, is that the FDA doesn't give full approval to it, then it is not reimbursed and you have to pay for it yourself. So I went to a Urology Association meeting, and I explained to them how you could treat prostate cancer with HIFU. And urologists would come up to me and say, boy, I hope this doesn't work. And I would say, why? And they say, well, I get half of my income from doing prostatectomies. Now, you know, we all have our turf guarding and so forth, but I think in the medical profession sometimes it can be a hindrance. There was this problem with acceptance in the clinical community because it displaced some people, and acceptance by the insurance companies because it was considered an experimental treatment, might fail sometime, and so they didn't want to support or reimburse the doctors for doing that. One of the problems in the United States is that there's considerable concern among the regulatory agencies that do no harm, and they take that very seriously. In China, the demands of the populace, with 1.5 billion people practically, means that they can relax those requirements. Many Chinese approach a physician with an advanced condition. That is, that the tumor is very large, they have already metastasized, their cancer is already metastasized. And so the Chinese clinical community are usually faced with extreme conditions rather than the sort of preliminary things when we do have ready access to primary care. And as a consequence, the Chinese have to take more aggressive actions against the disease than the US, where we have lots of screening and so forth. And so I think that the approach of the Chinese government to say, well, look, we're trying to save lives here, we're trying to treat an advanced condition, is really a different case or a different scenario than what's happened particularly in the United States, where we have a lot of screening. And so their regulatory agencies understand that and allow these more aggressive treatments. Every time a graduate student would come to me and want to work in my field, they would often say, what's the future? What's my career future if I work in this area? Listen to me. This field of image-guided transcutaneous bloodless surgery has got to be the future of medicine. And if I were you, I'd want to get into that field. I think it's undeniable that this is the future of medicine.